we're going to be going over gynecologic emergencies and OB emergencies this week. Both of them, two, again, very good subjects. Unfortunately, we don't do a lot of gyno or OB, and I shouldn't say unfortunately, fortunately, we don't. But when we do, unfortunately, it catches us off guard. Biggest reason is it's not something that we concentrate on once we get out of school as much as we should. These are patients that you're going to be dealing with that have special needs or that go against normal medical rules. And we're going to talk a little bit about that. And the reason is because of the physiological changes that take place both to the woman during pregnancy and during OB, and then gynecologic emergencies that may make things not work like they should. Things may not present like they should. And again, most things that we go on don't. And that's why they normally call an ambulance. So, but we're going to be touching on those. Again, not going to go through the entire program, but we're going to hit the hot spots and things that I think that are very noteworthy that ought to be brought up. So we'll start with gynecologic emergencies. Basically on these, and let me make sure I get my pointer going. There we go. Okay. Gynecologic emergencies are usually associated with, one of the following signs or symptoms that we're going to see in the field. Okay. And this is going to range, and these are not limited just to this, but these are the basic ones that we see in the field when we get called as an ambulance, most generally. Vaginal bleeding, of all sorts and all kinds, abdominal pain and tenderness, vomiting, fever, tachycardia, hypotension. Those are just a few of the things that we are going to see. Syncope, diaphoresis, changes in stool patterns. And as you can see, a lot of these will tag team with each other. Okay. So you'll have some hypotension, which causes syncope, with some abdominal problems with bleeding, which causes hypovolemia due to blood loss. A lot of things, a lot of these signs and symptoms are going to be caused by each other, or they're going to, precipitate one after the other. So, but these are just a few things that we're going to see within the world of when we're dealing with gynecological problems with female. And you're going to hear me say this several times throughout a lot of this. If you've got a female partner or, somebody that is on duty and you get called for this and the other truck happens to have a female on duty or whatever, it's highly recommended that they take it if they can. Again, I'm not trying to put more work on one person or not, but I can tell you right now, just speaking with most females, that if they have a problem like that, they would obviously rather have another female working on them, if at all possible. The last thing they want is some guy trying to help them out, even though with their best of intentions. So, if a female is available or around, let them take the call if at all possible. Unfortunately, sometimes this may be a paramedic call, and your partner is a female, but they're an EMT. So this might be a call to where can you get, and again, I don't know what your policy and procedures are, can you get a first responder to drive you? So that your partner can be back there with you? Or do you have another truck that's available for somebody to come drive you guys real quick to the hospital so that your partner can be back? So even though they may not be the highest trained person, that doesn't mean they can't be back there also for nothing more than reassurance, for the patient at that time. So that's just something to keep in mind, if at all possible. If it's a female, if it's a gynecologic problem, an OB problem, try to get another female involved if at all possible, or at least that can go with you. And it may be one of those things to where if you're transferring a patient out that has OB or gynecological problems, and you got two guys on the ambulance, and there's going to be a lot of checking going on or things to get, keep in mind, and they've got an extra nurse and your protocols allow that, see if that nurse can go with you, especially if they're an OB nurse or a gyno nurse. Those would be the best thing in the world, because that's what they do all day long. And I guarantee that patient would prefer that if at all possible. I'm not saying you can't do your job. And we know everybody can on that end, but it's going to be easier for that patient and less apprehensive, and they're not going to be quite as anxious, which the anxiety in itself can precipitate other problems, so just something to keep in mind. If at all possible, try to get a female that can help with them. Scene size up on this is going to be just like any other patient that we're dealing with. We're going to take care of the ABCs, obviously. The biggest thing is when you've got bleeding going on, we need to kind of have an idea of how much. So this may be, in surgery and even in ER and stuff like that, we'll usually have a pad count. In other words, if you've got a bundle of 4x4s, or a 8x10 or a 6x10 or 10x12 or whatever trauma pad that you're dealing with, you'll know how many were actually soaked up. So when you go to a residence on these patients, try to get an idea of how much blood has actually been lost. If they've got, 2 towels that are just completely soaked or whatever, or you've got blood on the floor, try to get an estimate. I mean, obviously we're guessing by all means, but they usually do when they're in the ER too, depending on what's laying on the floor. So, and the reason for this is to give the ER and the OB department or gynecologic department a better idea of how much blood they have lost. Obviously, they're going to do labs, they're going to check and see what their hemoglobin level is. But it's always good to know, hey, they've lost half a liter of blood, or they've lost a liter of blood, or so forth. So these are good things to help not only the ER staff and everything else, but you kind of get your mind going on, hey, we're getting ready to deal with hypovolemic shock on this patient. I need to get a large bore line going on them. I need to get some fluids in. Maybe this patient is to a point that where, it's 30, 45 minutes from the hospital, and I've got a chopper that's 2 minutes away that has blood, and this patient needs blood. So that might be the one time that, waiting for a second for the chopper to get there because they can't give blood might be the appropriate action. So, but it's just one of those, again, everything's situational. Everything is playing detective and trying to figure out what the best plan is for your patient. Again, at the end of the day, if you have your patient's best interest in hand, you're doing what is right for that patient. So, but try to make the best decisions you can with the information that you have got at that time. History taking on these patients, and it's a little bit, beyond normal on that. You need to find out when was your last menstrual cycle or when was your last period. Was it regular? Was it heavy? Whatever. And explain to them why you're asking this question. Tell them, hey, we're trying to get an idea of, is this normal for you? Is this not normal? Did you lose a lot more blood than you normally do when you have your period? But it also, in essence, tells us that, the potentiality of there not being a pregnancy if they're actively on their period at this time too. So that definitely tells us something. Or were they pregnant before? What was this, a possible spontaneous abortion or whatever that happened to the patient? So, it's just things like that, but it's questions that you normally don't ask when you're doing a sample history or an OPQRST or DCAT BTLS or any of the other acronyms that we use. When it comes to a gynecologic problem, you're going to be asking more and different questions in order to get the proper information so that you can get the proper treatment in line for this patient. So a lot of these can be embarrassing and probably will be embarrassing, especially if it is a young female and maybe even an older female. I mean, it's not for me to, say who and who is not going to be embarrassed about it. So get down on their level, talk to them, face to face, and explain to them why you're asking these questions. Let them know, hey, these will help our treatment plan. I know that some of these questions might be a little embarrassing, but we do need to ask them. One of the things that you can do to help with that situation is don't ask them in a big crowd. If you've got 8 first responders and, everybody crowding around this patient, it's going to make it hard for that patient to sit there and answer you honestly if they're very embarrassed about it. Get them in the truck with you and your partner, you and somebody else, and sit down and, hey, it's just us. We got some questions we need to ask, and do your best to give them as much modesty as you possibly can. Okay. So in other words, if they're bleeding and everything, try not, if you can, I mean, obviously life over limb here, but if you can, try not to expose them, or do anything in public that you could do in the ambulance, and give them a little bit of modesty every chance you can. They're still a patient. They're still a human being. They still get embarrassed. So, do what you can to help keep that modesty intact. Not only is it better for the patient, but that patient's going to trust you more, knowing that you're doing what you can, to help take care of it. And no different than if you were doing a 12 lead on a normal patient. Let them know, as long as it's the truth, that the back glass of the truck is tinted. It cannot be seen through very easily. So, we need to expose your chest just for a minute while we put the electrodes on, and then we will cover you right back up. But explain to them, nobody can see out that window or see into that window unless they can. I mean, don't lie to your patient, but most ambulances these days, especially the last 10 years or better, have got some kind of a tinting or a sticker or something that forbids people from looking in without just getting right up to the glass. So let your patient know that. I think that will maybe put them a little bit more at ease when that's going on. Again, like we talked about, try to use the same gender if at all possible. If not, and you do have a female partner, get them back there with you, even if you don't have anybody else to go with you, so that patient can, while you're asking these questions and doing your preliminary ABCs and starting an IV and getting a 12 lead and doing whatever needs to be, have your partner back there, reassuring them and being with them as much as possible. Again, at the end of the day, show respect, show modesty. They're a person. They've earned it. I mean, there's no doubt about it. So, okay. Trauma on these, okay? Management of gynecological trauma. Female genitalia is very highly vascular. So is the male genitalia too. You can actually fracture your penis for better. And what it is it's a vascular fracture, and they can end up dying from that. So, but the female in the genitalia area is very, very vascular. There's a lot of blood flow in that area. So any kind of trauma in that region you lose a lot of blood. They can bleed out pretty quickly. And, a lot of times applying external pressure usually takes care of the problem within that area. One thing that you do not want to do, okay? And I know, we've got the new Stop the Bleed classes. Everybody from day one and first responder all the way through paramedic or nursing or anything else. If there's bleeding, direct pressure, stuff that wound and everything else, okay? We do not do that if there's a vaginal bleeding. You do not fill or pack the vagina, okay? You just do not do that. That's not a good deal. External, yes, okay? And like we've always taught, okay? Sometimes you can't get away with it, but most of the time you reapply over the top. You don't rip that other bandage off. Chances are you may have got a clot started and you're going to rip that clot off in a heartbeat. So, you can pack outside, pack them, on top of each other, but do not pack the vagina itself if there is bleeding. That's not going to help you. We're going to do everything we can. You're going to treat this patient for shock. You're going to, put them in Trendelenburg if you need to, large bore IV, give them fluid, give them oxygen, put a blanket on them, do everything you can to treat them, and, diesel, get them to the hospital as quick as possible with everything that you're doing. So, getting an idea of why the trauma happened or what happened to that may give you a better sense of what's going on and what you need to do to help prevent this from happening, or at least get it to stop somewhat. So do what you can, but just do not pack it. Okay. One of the disease processes that we don't do a lot into, and most females obviously know about it because of things that they have possible involvement with, especially with tampons and things like that, is PID, or pelvic inflammatory disorder or disease. It's basically an infection on the reproductive organs. It is a complication of an STD, and it can occur with other infections. Okay, so if if the patient's got another UTI going on or another infection process, a PID can actually stair step off of that and happen. it's a very painful situation for them. It's going to hurt. You're going to see possible swelling around the uterine area, and it can actually make the fallopian tubes expand, including all the other anatomy in that area. It is abscesses can form. There's nothing we're going to do in the field. Okay. We're going to treat them just like anybody else. ABCs, get a line in them, get them on oxygen if necessary, treat for shock, anything of that nature. But there's nothing that you're going to do, barring maybe some pain control, that might help with that. And it usually, the pain from these usually start either before, during, or after their period that they've got going on. And it's going to usually be a lower abdominal pain on these patients. They may have vaginal discharge. They're going to have fevers and chills, pain or burning urination. So it's going to be almost like a UTI, but a lot more involved. Okay. To where UTI, normally you can possibly hurt up in the kidneys, kind of like a kidney stone effect. They're going to have a lot more of an abdominal involvement with this than they normally would with the others. So, but again, at the end of the day, we're going to treat what we see, the signs and the symptoms, and get them to the hospital. Obviously, they need to get on antibiotics for this to help them with that situation. But again, untreated, any kind of untreated STD can actually promote these. Frequent sex with multiple partners, douching used to be a real big deal. I mean, it was just forever. That was the way to go for cleansing and stuff. And obviously they've stopped that. And because it caused a lot of infection, and it got rid of a lot of good things, a lot of the good bacteria that's in there that they figured out. So they've definitely gone away from that. Any kind of abortion or childbirth can cause it, and an IUD that is inserted can also cause a pelvic inflammatory disease. So if they've had an IUD placed, in the last little while or whatever, and that is something to ask them too. If they've got severe abdominal pain and cramping, they painful urination, things of that nature, ask them, have you had any procedures done recently? And yeah, I had an IUD placed, a month ago or whatever. So that's good information. At least it gives the practitioner somewhere that they can go with this at that time. So again, it's embarrassing for some patients. Some patients will just spout it right out. So, but getting them in the truck and getting them away from the crowds is going to get you more information. And I mean, you guys know that anyways. You've already been dealing with that as EMTs and it is as advanced and other practitioners in other areas. So these are things that's just trying to build upon what you know and what you've done in the past. Okay. Again, there's some on here that I'm not going through, but I do recommend you guys go through the whole thing, obviously. Ovarian cyst is another thing that you may come across that can actually be life-threatening for the female patient, but can also cause a lot of pain and a lot of problems. Basically, it is a fluid-filled sac that is on or within the ovary itself. It develops and it can be in a ruptured or unruptured ovarian follicles. Typically, they last about 8 to 10 weeks before disappearing without any complications. They may cause pelvic discomfort, urinary retention, or where they just feel like they cannot go pee because of the swelling that's in that area, or they feel like they need to urinate frequently. And it can also cause them to have abnormal or irregular periods or menstrual periods that are going on at that time. So ovarian cyst, if it's their very first one, they may not know it, but unfortunately, females that have had them before sometimes will get them later on, and they'll actually know when they that they've had them before, and this is kind of what it was before. So they'll be able to tell you, hey, I've had ovarian cyst before. It felt like this. This is what I think is going on. Again, it's decent information. At least gives you kind of a pathway to go down. Now, the biggest worry that we have is that these spontaneously rupturing, and they any kind of abdominal trauma car accident, the patient fell, God forbid they got hit in the stomach, something along those lines, or even intercourse itself, or a lot of kind of exercises can actually cause them to rupture. If they do rupture, their symptoms may be nothing, could be mild, or could be massively severe. It just truly depends on how big the abscess was, where it was, and what happened to actually cause it to rupture at that time. But usually lower back, abdominal pain, discomfort that actually can radiate toward the back, are things that you're going to see on that. And again, when they rupture, it can be very painful on these types. Normally, we don't see massive life threat on them at that time, but obviously it does need to be checked out and make sure that there was no bleeding involved with, if the ovarian cyst happened to be on a blood vessel or around a blood vessel when it ruptured, causing internal bleeding or anything. But the other one is an ovarian torsion. On guys, we're dealing with a testicular torsion, but an ovarian torsion is pretty much the same. It's a twisting of the ovarium, in that the blood supply is pretty much interrupted to where no more blood supply can get to that area. We all know that when blood supply is shut down from one area, that other area, if it's not put back into place and the blood flow reinitialized, that area can die, and it can actually cause lots of problems, including infections and sepsis and everything else with that. So this is something that definitely needs to be fixed as quick as possible. It's usually considered to be a lower abdominal pain, and it is severe, or symptoms worsen, they're going to feel it more down in the lower abdominal area. A lot of these patients may have a history of ovarian cysts. That's kind of where that comes into play, just knowing that they have that. If they have a history of ovarian cyst, then I'm not going to say that it pregnates them to have a possible ovarian torsion, but it's highly likely that it could take place. This is something that is surgical. They've got to go in surgically and basically get it back the way it goes. And if not, it will lead to permanent damage to the ovary, even to the point of death to the tissue, to where nothing can be brought back like it's supposed to. Again, on this, it's going to be very tender to the touch. Sometimes there will be a mass in that area because of swelling and infection that's causing in that area. But absence of those findings does not rule out a torsion. They need an ultrasound, need a CT of that area to see what's going on with that at this time. Pre-hospital treatment on it, guys, is just pretty much the same that we always do. We're going to ABCs, 1, 2, 3s. We're going to help take care of that patient. Recognition of this situation is definitely something to keep in mind. And that is one thing that we usually do when it comes to the abdomen area anyways, especially on a female. If they're having severe abdominal pain, they're having problems urinating, any kind of blood discharge or anything of that nature, and they're of childbearing years, and we'll talk about it in a little bit when we get over to the OB side, is an ectopic pregnancy. So we're pretty high on anything to do with abdominal pain, swelling, tenderness, things like that on a female patient, of it being possibly a life-threatening situation. So, but passing that information on as quick as possible when you get to the hospital is very important, so that they can get that checked out and get it fixed. One of the other disease processes and issues that we see is endometriosis. This is basically an inflammation or irritation of the line of the endometrium. This is something I'm very well knowledgeable about. I have a family member that has this. So it is something that can just unbelievably change in minutes. I mean, truly minutes on these, especially somebody that has had a long history of it. It's often associated with bacterial infections. It is more likely to happen after a baby or a miscarriage on a lot of these patients. Fevers, chills, vomiting, tachycardia, lower abdominal pain, possible foul smelling discharge. As you can kind of see a history here, all of these are having a lot of the same type of symptomology for these patients. So again, we're not going to quite know exactly what's happening in the field. We don't have the fancy toys to really get us in there and see exactly what's going on, but we can at least document and get those signs and symptoms as quick as possible to the tertiary facility that we're going to hopefully get those looked at. Management of endometriosis, reassurance, put them in a position of comfort. If they need an IV, go ahead and get one started. I would recommend getting one if they don't mind. Some services do blood draws for their hospitals if they're close enough. But it's basically where the tissue grows outside of the uterus. Okay. Unfortunately, what it can end up doing is cause adhesions to where it will basically grow on and around the rest of the anatomy in there. You can even have it to where it will connect itself to other areas in there. You can have it off of a kidney or off of another part of their anatomy at that issue. And this just causes pain, swelling, tenderness. And I mean, they can have swelling that is just unbelievable. And I'm talking within 10 to 15 minutes, they can be flat belly and then almost look like they're pregnant. So, I mean, it's just unbelievable what can happen with that. And again, most of the women that have this problem know they have this problem, and they can let you know what's going on at that time. Normally, if they're calling you and they do have this problem, then it has gotten worse and it's beyond what they can control at that time. So again, be respectful, be mindful of the situation, and do what you can, but reassure them, we're here to help. We're going to do everything we can to help you with this. Some of the things that, if they haven't been diagnosed, and the reason we ask about periods and how heavy, if the flow was normal or not, is heavier prolonged menstrual flows is one of the main indicators of endometriosis. Again, it's not a have to, but these menstruals will be super painful and cramping more than any normal period that goes on. Any kind of intercourse can be very painful for these. They will also have pressure or urgency around the rectum area, feeling like they need to go to the bathroom when they don't really, because of the swelling in that area. Very fatigued. They're going to be wore out, and they will actually have some bleeding and spotting between their periods. So beyond their period window, they will still have some bleeding and problems going on at that time. Again, pain relief, if they have a history of it, they have a history of it, and it's within your protocols, manage their pain. Give them some pain medicine. This is a very painful situation and very disheartening. I hate to even think about it. If you've got a loved one that's ever had it, or you've had it yourself, I very much feel for you. And if you're in pain, by God, you need some pain medicine on that end. Same thing with people like kidney stones and stuff. I have no problem giving pain medicine when it's something like that. Unfortunately, if they don't have a history of it and they've got some abdominal issues, most of our doctors do not want us giving pain medicine until they get there and they can do a proper checkout. But if they've got a previous history of this and we know it, and this is exactly what they've had before, then usually it's not that big of a deal for them to get some pain management at that time. Uterine prolapse. I personally have only seen one of these, and it was in an ER. I did not actually transport the patient, but it's basically to where a portion or all of the uterus is actually outside the vagina, and it basically, your cervix drops, but it remains in the vagina, and it can be just, you're like, well, what in the world do you end up doing with this? Obviously, there is going to be not a whole lot that we can. Unfortunately, this is usually a genetic disposition on these types of patients. Obesity can be one thing that can cause it, a weakening of the pelvic support because of decreased estrogen. So if they've got some hormonal issues, that can also cause problems with this. And, increased, intra-abdominal pressures related to pregnancy, or if they've had a difficult childbirth and everything has gotten stretched more than it normally would to where it just cannot hold this in like it should. And again, back pain, fatigue, pelvic heaviness and fullness are going to be signs and symptoms that you are going to see with this patient. Again, do not put the tissues back in. We do not replace those at this time. Cover them with a warm, moist dressing. And, I know it's kind of hard sometimes to find a warm fluid, but if you guys carry a fluid warmer, then, and got a couple of bags of saline in it, perfect. Grab you a bag of saline, pour it on a 4x4 or a 6x10 or 8x10 or whatever you've got, and cover that and keep it warm and moist during the transport of that. If you've got an occlusive wrapper, once you put that moist dressing on, and here's the biggest key, and I know you know this from EMT class, but most of your trauma pads come in a package that one side of it has a clear screen. That is purposeful. And a lot of people don't realize this. That is an occlusive dressing. Now, there's some of them out there that's just a paper sack on both sides or whatever, but a lot of those came with a clear window on there. That was that way because you can take that and actually cut out or create that as an occlusive dressing. So if you can get some more warm, moist pads or whatever on there, take that and just kind of wrap it around that area to help keep that moisture in because drying out, it's going to make it, it's going to be necrotic for the tissue. It's going to be more painful for the patient. So it's just keeping it moist. Everything is going to help them once they get back into where they can get that back where it needs to be located. So, but again, on a prolapse, we're not putting it back in. Same thing with a rectal prolapse. Not going to happen. Fun fact though, on that rectal prolapse, it will blow your mind if you get the right doctor in the ER. One of the biggest things they use to retract a prolapse rectum is sugar. I know, look it up, but actually taking sugar and putting it around it, it'll make it pop in. I've seen it with my own eyes. So again, off topic, but it kind of went with the prolapse thing. So fun fact for the day. Okay. Vaginal bleeding. Just kind of roll through this a little bit and talk about some of the things that you're going to see and that you can do to kind of help with this. Usually the risk factors for vaginal bleeding or issues going on obviously can be anybody. However, these are some of the things that can actually end up causing or predispose them to get it. Extreme weight loss or gain can be one of them. Anybody over the age of 40. And I'm here to tell you right now, after you get past the age of 40, your warranty just goes out the window for your body. So you start getting up and everything's popping and creaking and everything else. So if you're under the age of 40, enjoy it, because once you get over 40, things aren't as good as they normally are. High stress can cause this. And again, look at the world we live in, especially post-COVID. And a lot of it is because we allow ourselves to get stressed out on things that are small that we probably shouldn't, but high stress can definitely cause this. Long-term medication use, such as contraceptives, things of that nature can be a possibility of that. Excessive exercise, somebody that exercises way too much. And then, of course, any kind of abnormality due to their anatomic, which could be caused by endometriosis or a uterine prolapse or anything like that. A lot of those things obviously can cause vaginal bleeding at that time. Supportive care, again, like we talked about before on the vaginal bleeding, you're going to just take care of the signs and symptoms, treat them if they're shocky, if they're trying to go that way, treat them that way, get fluids on board. Again, don't Kool-Aid them. We don't want to get to the point where we're not doing them any good. But if fluids need to be there, by all means, get in there. Traumatic events on it, again, you're gonna pack the outside, not the inside. Put you some 8x10s, 4x4s, whatever trauma pad, and direct pressure. Try to get it to start clotting on that end. warm IVs, oxygen, put put a blanket on them. They're going to have a hard time regulating. Anybody in shock is going to have a hard time regulating their body temperature. So make sure you do what you can with that. And again, these are going to be a high priority transport. These are somebody that you're going to need to get them moving as quick as possible. Let's see here. Okay. Sexual assault. And unfortunately, this is something that you're going to deal with. Again, like we said before, if you have a female on duty, they really need to be the one helping with this. Okay. The last thing somebody wants is the same sex that has violated them coming and trying to take care of them. Now, sometimes we don't have a choice. If we've only got 2 guys on the truck and nobody else is available, we got to do what we got to do. But again, we can get them out of the crowd. We can get them into the ambulance. We can try to get another female, even if they are not medically trained or anything else, just to be there as a comfort, and I've had this happen before, to where we got, grabbed a female first responder and said, hey, can you ride with us? And absolutely. And most of them will if they can. And just that is enough to help the anxiety level of the person with that. Obviously, anything that is not consensual is considered rape, according to the law. And this is oral, anal, vaginal, any kind of penetration, any kind of body parts, using any kind of force, threats, bodily harm, taking advantage of a victim who is incapacitated and who is unable to give consent. So, I mean, it's a wide range of things that you're going to deal with. You may be called right after the event happened. This could be 24 hours ago. So again, it's going to be different depending on, whether it was just now or 24 hours from now, on how the patient may be acting at that time. They may have had a lot of time to think about it. They may just now decided to go. They may just now start hurting. It could have been 2 or 3 hours ago and their adrenaline's wore off and now they're in a lot of pain and they do want to be checked out. One of the things that you do need to do as a paramedic, you need to try to transport that patient to a facility that has a sane nurse. Okay. And I'm not saying mentally sane. Okay. It is an actual sane nurse that is a qualified sexual assault nurse that can do the proper collection of evidence and who also knows what paperwork to properly fill out to make it very legal. So most facilities, if they don't have one on duty, they have an agreement with another facility, or they have somebody that's on call that may come in for several facilities. So in other words, if you live in a rural area where your hospitals are really small and they don't necessarily have one on duty, they may have one that is one county over or that belongs to this hospital, but they have an agreement to come over here. So the best thing to do is get a hold of medical control for the facility that you normally would go to and ask them if they have a sane nurse on duty and or do they have the availability of getting one in there. If they don't, ask them if they know of the next best facility to go to. Unfortunately, if you're the only truck in town, you may not be able to transport them where they actually truly need to go. But if you are, and you do have that feasibility and, it's another 20 minutes down the road or whatever, if it's got a sane nurse and they do not have life-threatening situation going on right now, then you need to get them to the location that does have the proper nurse for that so that this can be handled the way it's supposed to be. So just food for thought on that. Again, and I know you guys are going to be this way, okay? But at the end of the day, professional, respectful, being very sensitive to the situation. Unfortunately, I've had several of these that I have transported. You've got to read your patient. And when I say that, you have got to know, is this the kind of patient that needs a hand on the shoulder? Or is this a patient you don't touch? Because there are some of those patients and they will normally, show you what they need to do or what they need at that time. They may be the kind that reaches up and grabs your hand or whatever. And I had one patient that just wanted to hold my hand the whole way there, and that's fine. Again, if we've got another female that can go or another person, I highly recommend having a couple back there. mainly so that the patient is comfortable knowing that there's not just one person back there, and so that you're comfortable knowing there's not just one person back there. And please don't take this the wrong way, but in the world that we're living in and the EMS that we have to work in, a lot of times it's good to have a second person there as a witness. That way, if something came back and somebody said, well, they tried this or they did this to me or they said this, we've got a witness, that's going to go one way or the other on that. Same way for the patient. That second person there is to protect both the medic and the patient back there. They're kind of a Switzerland, a neutral go-between, if you would. It's just a second set of eyes and a second historian of what's going on with that situation. So if at all, and that may be a deputy, it may be a police officer or highway patrol, whoever that might be able to go with you, I highly recommend you have a second person, if at all possible, just so that everything's on the up and up and you're taken care of and the patient's taken care of. And it's very, very important. One of the things you don't think about a lot, men or women can be the victim here by all means. If a man is a victim, you need to be very careful and not make them feel like, they're, or belittle them for turning this in or showing a response on this, because, they're already probably embarrassed about even bringing it up at that time. So be respectful, be professional with them, treat them just as you would anybody else at that time. It's a crime and it needs to be dealt with. And if it is a rape and it is a rape, you have to report it. So it's definitely something you're gonna have to report. Now, what the patient does with the officer or what they decide after that point is up to them. But you did your duty of reporting that happened at that time. So, but you've got to report that. And most facilities and places you work for, it's a mandate. No different than geriatric abuse, child abuse, anything like that is pretty much mandatory. Most of it's lawful. Most of it is a law that you have to do. Do what you can, with getting a female there if you can. Limit your examination to a brief survey, check for life threats, okay? Get some vitals and call it good. You don't need to get into heavy secondary unless you see something that needs to be dealt with. If they've got bleeding going on or anything of that nature, do everything you can to take care of the problem, but don't do any more than you have to do on this patient. It's just that way that they just probably don't want somebody touching them at that time. Protect their privacy by all means. Don't record anything or get on Facebook, which I know you're not. It's HIPAA violation, but it's definitely a big HIPAA violation with this. Examine a patient with minimum of people present. Again, have one extra and that's it. And provide treatments both physically and emotionally for this patient. Right now, all that patient may need is an ear. They may need somebody to listen to what's going on. Let them, okay? And if you ask some questions or they ask some questions or whatever, answer what you can legally. Don't try to, you're not a lawyer. You're not a police officer. Even if you are, you're not at this moment in the back of that truck. So you do not need to be telling them what they need to do or how they need to do it or whatever when it comes to the legal side of the house. Right now, all we're dealing with is the physical and emotional side of the house. Help them with that. Law enforcement or whoever's doing the investigation will take care of the rest. Okay. Double checking here to make sure that's all I wanted to do on that end. Again, there's a few more obviously that on this to where you can go around and kind of go through that we did not touch on. There's some of the anatomy. Obviously, I'm not going to go back over general anatomy on that. That's stuff that you learned in basic class, and you're going to learn a little bit more here, but that's something you'll do on your own and kind of go through on the anatomy. So, okay, I think that takes care of the gynecologic emergencies, and we're going to go ahead and get started with OB emergencies. Okay, we're going to get started here again, like before. in the OB section here, we're obviously not going to be able to go through the whole thing. I mean, it's like 140 slides or whatever. So I don't want to grill you guys on for 3 or 4 hours here. But we're definitely going to hit some of the high points. I am not going to get into the anatomy portion of it. That's something you guys can do on your own. You already have done. Most of it is, stuff that you've had before. It's just refreshers. So, but I do ask that you do make sure and go through the whole program. It's only going to help you in the very long run. So, okay, on OBs, gestational period, as most of you all know, in a normal sense, if there is such a deal, from it takes the fetus to development in utero about 38 weeks, approximately. Now, obviously, this is very, motivated one way or the other by a lot of different factors. You'll have some that end up going to 36 weeks, some that go to 39 weeks or 40 weeks before the doctor will induce and go from there. But under normal circumstances and for legitimate reasoning, we'll say that 38 weeks is your gestational period, and it is normally calculated from the first day of the pregnancy after the women's last menstrual period. So, and again, this is usually something that they're pretty accurate on anymore. Years and years ago, obviously they'd use a scale and a cycle calendar to try and work it out, and they'd usually be fairly close. But anymore with programs, and if they can get a pretty accurate date of when the last menstrual cycle was, they can get pretty darn close. Some of them usually within just a few days of that. But that's usually what we're looking at there. What I want to talk to you about right now are some of the physiological changes that happen to the pregnant woman while she is going through pregnancy. Big reason why on this is when you're dealing with a patient, you need to understand what has changed. Okay, you need to understand that this patient, has got 50% more blood supply. They've got a lot more blood in their system, that it's not unusual for their heart to go up 15 to 20 more beats during a pregnancy. So those are some of the things we're going to kind of go over. And again, those are very, very important when you're dealing with and treating your patient, because what might be considered not proper or bad for one patient may not be the same thing with an OB, or vice versa. One thing that's normal may not be normal for them. So knowing, kind of having a good idea of what happens through the progression of the trimesters and how their body changes is at least going to give us a better idea when we have to go to treat them and what you're dealing with on this. So, pregnancy can and will exacerbate and create all sorts of medical problems or medical conditions. And if a patient is in a trauma, a car accident, a fall, anything like that, the body can definitely alter what its normal response would be to that. Okay, the body's going to protect that baby. Okay, it's going to protect it at all costs. So it's going to do different things to change that we normally wouldn't see on that end. Significant changes that you guys are going to see on this, and I really don't need that one. Hang on just a second. See what I had here. Okay, yep, we did on that. Okay, there's a lot of pressure that occurs in the intestines and the rectum. Everything is getting pushed. Keep in mind, this baby is getting ready to make room, and everything's got to go somewhere. That's why your pregnancies cause females to be a little bit short of breath. Their diaphragm can't quite allow, for a full exhalation or inhalation. Everything gets pushed up there. Their uterus and everything obviously is going to start growing on that end. But the biggest thing is, and I'm telling you this from just knowing from my wife having 2 kids, their bladder gets constricted to nothing. I'm telling you right now. So if you're going to go on a road trip, you better have good bathrooms planned out. Any good pregnant woman can tell you where the most cleanest and best bathrooms are within a 100-mile radius. And I'm not even joking. So it's definitely something that definitely changes for them. Let's stomach is not emptied as quickly. So in other words, like you would for digestive purposes, it won't happen near as quickly. The kidneys do increase in size and volume. Keep in mind that they are taking care of an infant now, so they are not only filtering for themselves, but filtering for that child. And obviously, like we talked about, the uterus increases in diameter, and hormones cause the skin, hair, and eyes to change. Okay, so that is one reason why, and I know this has nothing to do with it, but my mother-in-law is a hairdresser. She always tells pregnant women, do not color your hair or do anything major to your hair because of the hormonal changes. Things are not going to turn out the way they should. You decide to go one color and it's going to end up green or something else. So definitely, it just kind of a food for thought, but kind of a funny deal, unfortunately. Circulatory changes, like we talked about, I mentioned just a little bit ago. The blood volume increases up to 50% in her body to meet the metabolic needs of the baby, adequate perfusion for the organs, and to compensate for blood loss during delivery. So, I mean, how awesome is the body? I mean, God definitely knew what he was doing when he made it. So it is not going to be unusual for that female to have up to 50% more blood volume during her pregnancy, especially after the second going into the third trimester. So that way, and with that said, that logically tells us that, she can lose a little bit of blood before it really is going to be a major issue with that. But we've still got to monitor. Keep in mind, you're dealing with two patients always now. So everything that you do to one does to the other. That's one reason why we do everything we can to get that mom back to homeostasis so that she can get that baby back to it. So just kind of keep that in mind. The number of red blood cells increase, obviously, with the blood. Clotting factors increase with fibrolytic factors are depressed. Okay. And the size of the heart increases. Okay. Cardiac output increases from 30 to 50% more with the child than it would be on a normal. So it is not unusual on an x-ray or a CT scan or anything else for the heart to look enlarged at that time, because it's going to. They got more blood, their heart's bigger, it's pumping blood for both it and the child. So that's definitely something to keep in mind. And like I said before, the heartbeat itself can go up 15 to 20 beats. So, our normal 60 to 80 on a pregnant female may be 80 to 100. So what we would normally call tachycardia, which is anything over 100 or 100 or more, may be normal for that female. Okay, so you get a female that's pregnant, that's in her third trimester, and her heart rate's 101. That doesn't necessarily mean she is got a problem going on or she's in distress. That truly may be her heart rate right now. So again, this will fall back to history taking on finding out, last time she met with her doc, what was your current heart rate? What did they tell you? Is this normal for you at that time? And as long as they're being seen by their OB doc frequently, then they're going to know this, and they're going to know, yep, that's normal. Since I've been pregnant, I've been running, 98 to 102 or 103. So that is normal for that patient. So with that, keeping in mind, with the heart enlarging and with the blood supply improving, you can actually see some EKG changes too, especially in lead 2. So that is not unusual in itself. So you put them on a 4 lead or do a 12 lead, you may see some EKG changes that, don't look normal, but are normal because the heart is increased in size, the blood volume's increased, everything is increased at that time, and you're going to start seeing some changes electrically on that patient. Each one's going to be different. I mean, there's no way in the world that we can tell you, you're going to see this exact change on this patient. No, you're not. No two females are the same. No two pregnancies are the same. You can have the same female that is pregnant 3 times and has 3 different outcomes, both, physiologically and everything. You may have problems with gestational diabetes with one, but not with the other. So it's all dependent on that pregnancy and what's going on at that time. Like we talked about, the diaphragm is pushed up by the uterus. The oxygen demand increases. However, the problem is with that diaphragm being pushed up, what does that do? It cuts their lung expansion down. So they're not able to get as much of a full breath. So it doesn't take much for them to get out of breath. In other words, them getting up and walking to the bathroom or whatever may get them breathing a little bit more because their body's demanding more blood flow, more oxygen, everything else. But the problem is it can't get what it needs because everything is smashed up. Again, baby's taking room up. It's creating room and space to where things weren't normally. So, that's not going to be unusual for one of them to get winded a little bit quicker than they would under a normal circumstance at that time. And because of that, the bronchioles that are in the lungs themselves will actually dilate even more to try to recruit and utilize more oxygen than they ever have. Okay. The body knows, it knows that, the body needs more oxygen, but it has lost some of its room. So those bronchioles will actually dilate and try to recruit more. And this will also to help regulate mucus production because the body's going to, possibly put out more mucus at that time. So it is not unusual for that to happen at that time. Along with respiratory changes on them, also, obviously, they do gain some weight, especially with the baby on board. But it is not unusual for the most females. Obviously, this can range low to high depending on the person, their metabolism, and what's going on. But usually an average weight gain of right around 27 pounds is normal for a female when they're pregnant at that time. And again, this is because everything is increased. The breast tissue's increased. They're carrying more blood. Their heart's increased. They got more proteins and fat deposits in their body that they're storing that they need for the baby for nutrition. So that's definitely not unusual at that time. Okay. And this is just kind of a little refresher. I'm not going to go heavy into this. Again, most of this. But you do need to know this really well and kind of go over it. If nothing else, make sure you've got a good flip book or something that kind of goes over it. Special terminology we use just for OB patients or for female patients of pregnancy. Gravida, okay, and this is the number of times that they've been pregnant. Okay, that they've actually been pregnant at that time. Para is the delivery of an infant who is alive at that end. So if they're gravida 3, para 2, that would mean they were pregnant 3 times, but only gave live birth to 2 at that time. So, and this is information that's pretty good to have, not only for you, but for the doctor. Kind of gives them an idea of how this woman does during pregnancy, and if she's used to having, any kind of issues with that or losing one of the children, they know that in advance. And as long as they're seeing an OB doc regularly, then they're going to know a lot of these beforehand. Okay, let's see here. Okay, substance abuse. And this is a sad situation, and I am not here to judge the mother. Abuse of any kind of a substance or whatever can be a disease in itself. Alcoholism, drugism, any of those. Those are things that, unfortunately, sometimes it's very, very hard to work their way out of. But something that is kind of a bad side effect of it is a lot of these will pass over to the baby through the placenta, especially illicit drugs. Meth, cocaine, any of the illicit drugs that you'll normally see will pass over that bloodborne through the placenta and will affect the fetus and the baby. And it can cause birth defects. The baby itself can become addicted and actually be born addicted. It's a very horrible sight to see that baby once they're born addicted going through detox, with their first hours of birth. Treat the mom, you're treating the baby. So, always do what you can to appropriately treat the mom so that you can do what is necessary for that baby. Spinal hypotension syndrome. Okay, this is one thing that actually you can deal with pretty easily. It basically what it is: the uterus may compress the inferior vena cava, kind of push down on the vena cava itself, and this can occlude and cause diminished blood to the heart. And obviously, if the mother's in jeopardy, so is the baby at that time. One of the biggest things you can do is place them on their left side, on the left recumbent side. What this will do is help take that pressure off of that vena cava and allow that blood flow to return to the mother and to the baby at that time. Treat the underlying causes if there are any, monitor them, obtain an EKG. If you need to start a line on them, if they need some fluids or whatever, definitely something you could do. But usually it's a positional thing also. That's why most pregnant women cannot lay supine. They cause that vena cava to be collapsed, which decreases the blood flow, which decreases respiratory oxygenation and everything else. So just by positioning and moving them, onto their left side, which takes the load off of everything, will usually cure that problem at that time. So positions everything when it comes for pregnant women, and they're going to tell you that too. It's hard for them to get comfortable in any position, but they do have to be careful. Laying flat or improperly can cause them and the baby problems at that time. Okay, hypertensive disorders that they will have with pregnancy. And usually these can be chronic problems that they have before they were pregnant, or that they have gestational issues. In other words, they didn't have high blood pressure problems until they were pregnant at that time. Usually these develop after the 20th week. 20 weeks seems to be the kind of kicker week, through the trimesters when we start seeing problems arise, if they're going to arise. Now, not always, but 20 is kind of the average week that if something's going to happen, usually we'll see it happen somewhere in that. A lot of these can resolve on their own. It may be just the body adjusting to an enlarged heart, more blood volume, things of this nature. So it's something that normally a doctor will monitor. If they don't think that the hypertension that's going on is very bad at that time, they may just monitor it and watch and see if it takes care of itself or not. Again, hypertensive disorders, these are risk factors that we got to worry about that can lead or preclude preeclampsia on these patients, which is a very horrible thing. And we definitely need to talk a little bit about this and things that you need to be kind of on the guard for, especially for an eclamptic patient, because it can be very, very serious. You can lose the mom, the baby, and everything on one of these. If this is a first pregnancy and it's and they're before the age of 20, is a possible risk factor. If they have advanced maternal age, which normally leads into the 40s and 50s on most of these. History of multiple pregnancies, if they've had multiple in the time, a pre-history of hypertension, like we talked about, any kind of renal disease or renal insufficiency problems, and of course, diabetes itself. These are definitely risk factors that can do that. Again, like we talked about, the 20th week seems to be the appropriate time factor that a lot of these issues and processes rear up and show their ugly face. And usually you're going to see, starting edema building up on these patients, the gradual onset of hypertension. So in other words, they weren't hypertensive and now they slowly have gotten there. And then they can actually check their urine output and they'll actually start showing protein in their urine. These are some of the things that they're looking for that could be a predispose of preeclampsia getting ready to start. So not necessarily meaning it is, but it's something that they definitely look for. If they do go hypertension disorder does kick in, depending on what's going on with that patient, depends on whether we need to do anything at that time. However, if this patient does go in and we do have to give emergency medications, that's something that we're going to have to do pretty quickly on that end. And we're not usually going to use stuff that we would normally use on other patients, especially if they've gone preeclamptic on us. But if they don't fix this, other conditions that are going to accompany preeclampsia that this patient's going to have is liver or renal failure, cerebral hemorrhage, abrupto placenta, or the HELLP syndrome. Okay, all these are going to injure, if not and or kill the mother, and in retrospect, take out the baby at the same time. That's why it's so important that they get fixed. Seizures is definitely one of the preeclamptic signs and symptoms that we will see on a lot of these patients. We're not going to use the normal. I know if we have a seizure patient, especially one that is tonic-clonic that is not stopping, we're going to use an anticonvulsant, whether your policy is to use Ativan, Versed, some you still use Valium, some forth. These are not medications that you can really use with the pregnant woman without the possibility of hurting the baby, because what you're doing to her, you're doing to that baby too. And if it's preeclampsia seizures, really the recommended medication that's going to stop and do any good is mag sulfate. Okay, well, we're going to give them magnesium. So, and one of the deals, and I know you've gone over some of your medications and stuff, but with magnesium, if we do start magnesium, something that we want to keep a big eye on with these patients are their deep tendon reflexes. Okay, we want to make sure that these stay intact and that they still are there, because if you're checking for those and they've gone away, then we're gonna have to back out on the magnesium. So that's one of the contraindications of magnesium, or that we need to turn it back down, is once they start losing those deep tendon reflexes. Complications because of the seizure of rupture of placenta, hemorrhage, any kind of intravascular coagulation problem to where the mother and the baby blood are mixing when they shouldn't. So, again, this is something that's going to have to be dealt with quickly and taken care of, or you're going to have two patients going down the tubes on you pretty quickly. Diabetes, another one, whether they had it before or it's gestational, can definitely be a problem area that we have to keep an eye on, especially with a pregnant female. And basically, it's just the body's inability processing carbohydrates during pregnancy. And a lot of these patients, after they deliver, they will, they'll no longer be diabetic at that point. But a lot of your patients, especially before they get to that point, they will test them to see whether they've got that possibility, and actually pre-diagnose them with that issue so they can keep a closer eye on that. Biggest treatments on it is diet control, just like with a normal diabetic, and oral hypoglycemic medications usually takes care of it. They usually don't have to go into an insulin based unless it's something severe. They usually put them on, like metformin or glyburide or one of the other medications that they use orally to help the diabetic patients. Okay. Talk about that. Respiratory. Okay, let's see here. Okay, bleeding related to pregnancy. Okay, some spotting is not unusual. Okay, now obviously, if it's her first pregnancy, she starts spotting a little bit, she's going to go to the doctor. She's going to get checked out, or should, to make sure that everything's okay. But normally they'll check her out, so it is not uncommon to see a little bit of spotting during your pregnancy. Okay. Now, if it is major bleeding, or they believe that there has been a spontaneous abortion of the baby at that time, then obviously it needs to be looked at. And this is usually if it's before the 20th week. 20 weeks is kind of, again, like we said, everything is 20 weeks. That's kind of our magical number there. If the fetus, if it's expelled before 20 weeks, it is classified as a spontaneous abortion or a miscarriage. Okay. So that's kind of the number there, because no fetus or baby is viable at that point. The lungs are not developed. Even if they were enough, there's not enough to work with. If it's before that, there's just nothing you can do at that time. And you're going to run on these calls. It's not unusual. I've personally seen one or two of them that were in a toilet when the mother was using the bathroom or whatever, and they were in their 17th, 16th week, and the baby was in the toilet there. There just ain't anything we could do. And it's going to be difficult explaining that to the mom, but there's nothing anatomically that we just can't do anything. It's just, and it would be a gross negligence on your part to even act like you could do something, because then you're going to give false hope where it cannot be there. You can have somebody that has habitual miscarriages. In other words, they just have several of these. These can be due to many different reasons, anatomical problems, genetics, anything that might predispose them to having issues like that. But a lot of these can be ovarian issues, whether they've had, endometriosis, or they've had some kind of a cancer, or surgical issues that they've had, malformations, the anatomy, something's wrong with it, cervical problems or conditions with that, infections, multiple infections can cause issues that they cause spontaneous miscarriages on this area. But threatening miscarriage, or threatening what they call abortions attempting to take place, is characterized by vaginal bleeding in the first half of the pregnancy. Okay, it can progress, or it can subside. Again, I said some bleeding or some spotting is not unusual, and a lot of it can take care of itself a lot of the times. Your position at that point is to transport and support the patient. Again, we're not going to pack the vaginal cavity. If they're bleeding, we're going to, put some pressure with some bandages and stuff to try to see if we can stop that. We're going to be supportive, treat for shock, Trendelenburg, blankets, oxygen, whatever needs to be done for that patient to help them at that time. IVs, fluids, again, you're treating the mom and you're treating the baby at that time. Okay. Ectopic pregnancy. This is one that is very, very serious. It's obviously impossible to truly diagnose in the field. There's just no way until you get in and they do an ultrasound to see if it truly is one. Basically, what happens is the ovum implants somewhere besides the uterus. Could be in a fallopian tube, or anywhere in that nature. They will usually have very severe abdominal pain. Just excruciating pain, and they can go into hypovolemic shock. So you can, their blood pressure can drop, so those are things that definitely clue you in on, we need to check this out. That's one reason why I ask any female that I transport that has severe abdominal pain, and I'm talking severe abdominal pain, one of the first things I'll ask them is, could you be pregnant, and when was your last period? When was your last menstrual cycle? And reason being is they could possibly be and not know it. It could have implanted itself, and they're just not showing any of the changes right now. So it is considered, any pregnancy, is any female patient of childbearing age with severe lower abdominal pain. That is one thing that we have to rule out. And again, we're not saying it is every time, but it's definitely going to be ruled out. We're going to get an ultrasound of that area and make sure that that is not what is causing this. Because if it is, this is something that has to be dealt with pretty much immediately, because it can become a life-threatening situation. Again, treat them for shock, and this is going to be a rapid transport. You're going to do there's going to be a priority 1 transport, lights and siren, get them there as soon as possible. Obviously, you need to get them to a facility that has an OB that can do surgical intervention for this patient at that time. Abruptio placenta. Basically, this is a premature separation of the placenta from the uterine wall itself. And this is something that if they are getting regular visits with their OB doc, this is something they can sometimes see, could be a possibility, and sometimes it won't be. But they will usually have a certain, and it'll be a sudden onset of severe abdominal pain. All of a sudden, just massive pain at that time, because it is literally ripping away from the uterine wall. So, it's basically like you ripping, part of your anatomy from the other. It's going to hurt. They no longer feel the baby moving at that time. And they have vaginal bleeding with dark red blood. That's the biggest one that you're looking for. You're not going to have that bright red blood, but you're going to have that dark venous blood that they're bleeding from at that time. Again, they're going to be shocky, and if they're not, they will be. So go ahead and pre-treat for that. Trendelenburg if they need to. Blankets, oxygen, IVs, whatever you need to at that time to help stabilize that patient. And you can check for heart tones if you want, but this is another load and go case. We're not going to stay and play with this. We're going to load and go and get them where they need to be, where they can, hopefully get in there and get something taken care of on that. Placenta previa. This is just where the placenta presents itself in the lower end of the uterus before the baby or before the fetus at that time, and it obstructs the cervical canal. Again, if the mother is seeing a doctor normally, this is something they're going to see or something that is a possibility, and they're going to work with that at that time. Obviously it can, as the baby pushes down on that, it can cause some hemorrhaging in that area. So normally their complaint, it's going to be painless. Okay. They're not going to be having any pain because nothing's ripped away from that. It's the, it is still there. The placenta is still there. It's just in front of that cervical canal with the baby pushing down on it at that time. This is going to be bright red blood versus the dark blood that we see on the others. So if they have pain and it's dark blood, you've got a detachment of the placenta from the uterine wall. If there is no pain and it is bright red blood, then there's a good chance that you've got a placenta previa that you're dealing with on that patient. And again, you're not going to do anything super special with these patients other than treat the signs and symptoms. You're going to take care of them like you would anybody else, and ask them if they have a history of this, or if their OBGYN has told them this is a possibility, or that they already knew that this was going on at that time. All right. Okay. Maternal and fetal responses to labor. Okay. When they are going into labor, these are some of the things that you're going to see both from the mother and from the baby at that time. The heart rate, the workload of the heart is going to increase dramatically because it's getting ready. It's getting prepared to go to battle, basically. And after a female has a baby, she can definitely tell you that she feels like she's been through battle, I'm sure. Blood pressure, pulse, and cardiac output is going to go up. That is not unusual. That is actually normal. Breathing rate's going to go up because the body is now demanding more of all of these. It's requiring more blood because it needs more oxygen, which is going to, increase the contractility of the heart. It's going to be squeezing a lot more and getting more cardiac output, more red blood cell production so that more oxygenation can happen, and more protein breakdown to help the mother make it through this situation here. The fetal response is going to be a decrease in the amount of oxygen and nutrients. And basically, they're not going to be removing waste. It can have a decreased fetal heart tone at that time, and it can go into fetal acidosis. So basically, the mother's ramping up and the baby's ramping down, and the baby's ramping down a little bit so that the mother can get what she needs. Okay. The body knows we're getting ready to push that baby out. So we're going to lower everything for that baby and increase everything for that mom to give her what she needs to have a successful delivery on this baby. So, birthing positions, again, a lot of this, if the mother's had babies before, she's going to know what worked for her. If there's a possibility of a breech birth or something of that nature, and as long as she's seen her OB doc, they're going to know a good idea of what it is. Unfortunately, you're going to transport some patients that have not seen an OB doc, most of it. So you're going to be flying by the seat of your pants on some of this. You're just going to have to wait and see what happens and then respond accordingly to that. Obviously, a lying position. If she wants to lie down and, get her feet up on the cot or on the bed there, if you happen to be at a hospital or something like that, or if you're in the house. And something to keep in mind, she and that baby are going to dictate where you're going to be. Okay. You may want to be on that cot on the way to the hospital, but if you show up at that house, she's laying on the floor, she's got her legs up, and you go do a quick inspection and you see, the baby's starting to come out. Guess what? We're doing this here. We're not going to move and go anywhere else because it'd be dangerous for the mother and the baby at that time. Standing births. This basically, the fetal head is moved away from the sacral area. So if you've got, if she's got a very small pelvis and a very small opening, sometimes they'll end up having them do kind of a standing birth type or a semi-Fowler's position. And the semi-Fowler's position is normally what we see most of them in. They're setting up halfway. Where they can get their legs in stirrups or whatever. Again, we're not going to have stirrups in the back of the ambulance or at the house. And so you may have to just improvise. And if you've got a couple extra people, they can be the stirrup for the legs to holding that in. Because if she has a very small canal area, one of the things you can do to help with this situation is to get those legs pulled back as close to the chest as you can. This ain't going to be comfortable. She's already not comfortable. She's already hurting. Things are not right. And now you're making it worse by putting pressure on it. But what you're doing is by pulling those legs out, you are separating that symphysis pubis down there a little bit to increase that canal size. So hopefully to allow that delivery to take place a little bit more normally. Or if the patients, when they come out, are coming out, where they've got wide shoulders and you get the head out, but you can't get the shoulders. By doing that, you might get enough room to where you can work with that. Like I said, semi-Fowler's is kind of one of them that you see a lot of them in at that time. So it just depends. If you're as a residence and they're laying on the floor, or if they're on a mattress or something like that, and there's a couple of, ottomans or little footrest or stuff like that, she can use those. Anything to help get those legs up a little bit is going to open that birth canal wider so that it's going to be a little bit easier for the mom and for the baby to come out without compromising the baby any more than it could be at that time. Kneeling birth and side laying position. These are things they can do, but honestly, in an emergency like this, most of them are probably going to be on their back in a semi-Fowler's type position that you're going to be dealing with at that time. While they're preparing for birth, or preparing for delivery, if the baby's not, moving like it should or whatever, some of them may have been told by their doctor, to lay on their side or to, kind of a frontal position where they lay down and arch their back a little bit. To try to get that baby to move downward a little bit. So these may be some of the things that works best for them. They may have delivered their last kids 2 or 3 times. Listen to the mom, okay? If this is not their first kid, they've already been to this ball game. You have not. So they know a little bit more about their body and what's going on. So listen to them within reason. I mean, at some point, sometimes, especially if you've got a prolapse cord or something like that, you're going to have to be dealing with this. They may not be able to do what they'd like, but, try and listen to your patient. Your patient's going to know, especially if this is not their first time. Your OB kit, get it out, get it ready, have some extra towels, things of that nature. Your OB kit has got a few little towelettes, things of that nature that you can utilize. Usually it has one suction that comes with it. Usually have a scalpel, some umbilical clips, things of that nature. I'll be honest with you. When I've cut the cord several times, obviously, yes, I use the clips, but guys, I'm going to tell you right now, that scalpel, trying to do that is just difficult, especially when you've got several people around and everything else. Use a good set of trauma shears, whatever, once you clip that, just use a set of trauma shears in the middle, just obviously, clip it where you're supposed to, away from the mom and between the baby. But once it's clipped, clip down, then just give it a snip. I'm not saying you can't use the scalpel, but honestly, it's just, I think you get a better deal with scissors on that if you've got a set. Okay, assisting. And again, we're not delivering the baby. Okay. All we're doing is assisting mom. Mom and God's got this taken care of. All we're doing is being there as a catcher and assisting with this. So the biggest thing that that you need to do, if you've never dealt with this before, is supporting the head. Okay. And so if you've already got the baby crowning and you can see hair or you can see the head starting to show, you need to go ahead and apply gentle pressure. Okay. We're not shoving the baby back up there. I don't care that you don't want the baby to be born right now. We don't do that. Okay. So gentle pressure. Reason being is you don't want that baby launching out too quick. Ripping, tearing, lots of bad things can happen when that happens. So all you're doing is holding nice, gentle pressure to allow, as that baby starts to come out, for you to just, you're not holding it in, you're just keeping the baby from shooting out too much. This is also going to let you know if you have got a nuchal cord or a cord wrapped around the neck or whatever. And I'm telling you right now, the very first time you ever deliver a kid that has got a cord wrapped around their neck, you're going to be like, oh my God. Okay. Again, you are the reasoning of calm here. Okay. If you freak out, she's going to freak out, and so is everybody else. Okay. So we're gently going to reach in using, and your middle finger works really great, and just run over that head, right under that cord, get your finger in there and just pull it back over. Okay. I've had to do it twice. And it's most of the time, it's not a huge ordeal, but you do need to get that cord unwrapped. Okay. It's not good for it to be wrapped around because the baby can't breathe once they get out, but also it can compress on that and will lower the baby's heart rate and oxygenation and everything. So you need to be very careful with that. Okay. Again, once you hold gentle pressure, once that baby starts coming out, you need to guide the head and the shoulders downward. Okay. So gently to put the head downward, and that way the shoulders can deliver. It gives them a little bit more space at that time. Once it comes out, you can gently guide the head and kind of turn it upward a little bit. So that you can try to keep it from having any meconium. When the baby is coming out, if they are face down, usually what I've had one do this as it was coming out. And what I tried to do was gently going right beside the head on the vagina and rotate your hand under and guide your hand with the baby's face in it to help it keep from getting any kind of meconium or anything running up its nose if you can. And once it starts out, then you can start to articulate just a little bit to get it on out. I mean, the best purpose is obviously is to be able to get the baby rotated to where the shoulders are up and down. Okay. Side to side is not good. Okay. Up and down is the way that baby is supposed to be delivered in a normal fashion. Obviously, if you've been called, there's a good chance that's not going to happen. But if you can slowly assist and try to get that baby rotated a little bit to where those shoulders, will be up and down, basically, to where we can get them out the proper way. And if the shoulders are wide, you may have to go up a little bit or down a little bit and kind of maneuver those shoulders to get one through. Once you get one through, the other one usually should come through without any big event. You shouldn't have much issue after that point. Again, you can read all the books you want. You can look at all the pictures you want. You can watch all the videos you want. Until you've actually done one, you're not going to know how you're going to react. But let me tell you, it's a wonderful thing, especially when everything goes the way that it should, to help bring one in. I mean, it really is. It solidifies you being a paramedic to the point that I can do this for another year. We work so many codes. We see so much drama and trauma and everything else in our lifetime that every once in a while, seeing a newborn baby come into this world and everything be right, it just kind of helps you remember why you do this. So a baby is just awesome. I mean, it really is a wonderful thing, and it will definitely help your outlook on your job without a doubt. Obviously, once they're delivered, you're going to try to clean the baby up, wipe it down if at all possible. If need be, we're going to suction. A lot of your doctors now are saying don't immediately suction unless they need it. But if so, then obviously we know that babies are mouth breathers, not nasal breathers. So if we are going to suction, we want to suction from the mouth first, because they're going to take that first initial breath, and then we can get the nostrils clear at that time. Wipe the mucus from the baby, clean them up, get everything clips in, get it snipped, and get the baby up on mom, okay, so that it can start bonding, but so that it can also warm up. If mom is going to breastfeed, go ahead and let her try and go ahead and initiate that, because not only is that going to help the baby get that colostrum that it needs to get its antibodies going on, it's also going to help mom stimulate. It's going to help her body to excrete Pitocin of its own so that it can help the delivery of the placenta and also help any bleeding to stop within that. So it's a wonderful deal. If they're able to breastfeed, then it's going to be beneficial to them by all means. Obviously, record the time of birth immediately so that you know this. You can even jump on the radio and tell dispatch we're now transporting 2 patients and let them log it for you so that you've got a good time and so it's recorded at that time. Wrap the baby up, any kind of a dry sterile wrap that you might have, or if you don't, just a good little blanket, give it to mom and kind of go from there. Apgar scores, again, I'm not going to go heavily into this. You guys know this, you're going over this. But we're looking at the heart rate, respiratory effort, muscle tone, reflex, irritability, and the color of the baby. And again, we want to do this at 1 and then at 5 and then 10 minutes on that baby, depending on what your policy, your procedure is for that at that time. Okay, we talked about cutting the cord, again, 2 inches apart, but between them before you cut them. Once it is cut, wrap it up in a dry blanket and get the newborn to the mom at that time. The placenta can be up to 20, 30, 40 minutes later. I've seen it as quick as 10. Again, do not yank on the cord. That is not how we do not want an abruptio placenta. You don't want to rip that from the uterine wall. You want that uterine to let go of it like it's supposed to. She may feel that she needs to push again. If that's the case, then that's a good indication that she is probably delivering the placenta, or you're delivering a twin, one or the other. And again, it is not unusual for when delivering twins for them to be spaced apart for a little bit at that time. But hopefully mom knows about that and she lets that little secret out to you at that time. With as good as ultrasounds are and everything else today, they pretty much can tell there's more than one in there. There's not going to be one hiding behind the other as easily as they used to. But again, if she feels like she needs to bear down, go ahead and tell her to bear down. And that will help deliver that placenta. Once that placenta is delivered, we need to keep it, make sure everything's intact on it. In your OB kit comes a sack, save that sack, put the placenta in it, tie it up. It needs to be delivered. The OB doc needs to verify that it is intact 100% and to make sure that everything is there that it's supposed to be. And there's some patients that, they'll go ahead and take a core sample of the blood and run some tests at that time. And there's some families that have core blood stored for that child should they ever need it later on down the line or something. So that'll be something that they'll want to do at that time. Once that has been delivered, it is not unusual for the mother to have some hemorrhaging or a little bit of bleeding going on at that time. If it is in your policy and procedures, you may give Pitocin after the delivery, but before the delivery of the placenta. This will also help, everything to shut down a little bit. If the bleeding just doesn't seem to be doing well on its own, you may have to massage the fundus. Mom's already been through heck, okay? She's already been, and you're going to make her really mad because what you're going to do is you're going to push in on her stomach and like you're kneading bread. And basically what you're doing is trying to get everything to shut down and to quit bleeding at that time. It's going to hurt. She's going to tell you that hurts, but explain to her while you're doing it and how this is going to help in the situation and help her to where where the bleeding will stop at that time. Something to keep in mind too, right after the pregnancy or even in the pregnancy at that time, IV medications may pass through very quickly. And also any other drugs that you give may go through a lot quicker than normal. So this means that they maybe have to get in higher doses. So in other words, if they're giving any kind of pain medication or any other kind of medication for this patient, for preeclampsia, for hypertension, anything of that nature, higher doses may be required in order to do any good for that patient. So that's just something to kind of keep in mind when you're in the truck. A normal dose of certain medications may not be the proper. And again, you can get online medical control to help you with that. I'm not going to go through the medications. You guys can take a look at those and kind of go through that. Okay, talked about that. Again, we touched on, but multiple gestations, if they got multiple children, they're going to be born. The first newborn is usually small, or the smallest of them. The abdomen is still fairly large after the birth. In other words, there's still possibly something in there. The second newborn is usually born within about 45 minutes. Now, again, this can change depending on the person and the situation that's going on at that time. It can be much quicker or it can be much later than that, depending on what's going on. With that said, you may have more than enough time if they're in the living room and you've delivered one and she doesn't feel the need to push or anything else. Talk to medical control, explain to them there's multiple babies. One has been delivered. She is not at this moment crowning or feel the need to push. We're going to go ahead and load her and start heading towards the hospital. And then obviously, if she gets to the point she needs to push or deliver that second child, we can pull over at that time and assist her with that. And that may be what they want to do. Again, for your report, you're going to define these as baby A, baby B. Again, you need a time of birth. So once that baby's completely out, tag it, by on the radio or write it down or whatever. Time of birth for baby A, such and such. Time of birth for baby B, such and such, so forth and so on. Again, this may be a good idea to have a second ambulance heading your way, just in case you do have distress with one of them. That they can deal with that while you're dealing with the other two patients. Because remember, every one of those you now have another patient that you have to care for. In utero fetal death. This will be one of the hardest things that any mother will have to deal with, but it'll also be very hard for a paramedic or a medical professional to deal with at that time. If the fetus dies in the uterus before labor, in other words, when that baby comes out, it is gone. It's gone. There's just nothing that can be done on that. They may know that this is going to happen. Unfortunately, at a certain point in the gestational period and everything, it may be to a point to where they cannot abort that fetus at that time to pull it out. It may have to be delivered with regular birth. And I mean, that's horrible. I mean, that mother has to go through all that knowing that she's going to deliver a stillborn. Your care obviously is focused on mom. I mean, that's just what it is. And it's going to be very difficult. And it's usually difficult to determine that is that way until it comes out, unless that her OB doc already knew that this was going on. Labor can occur up to 2 weeks or longer after the fetal death. So this baby may have died, and then 2 weeks later it goes into labor, or it can last longer than that. Labor usually progresses normally. Unfortunately, there's just nothing you can do at that time. And do not attempt any kind of resuscitation of an obvious dead baby. I mean, if that baby comes out and it has been dead for quite some time, I mean, the color, everything is just way off. I mean, that this baby is not even close to being viable. Don't attempt it, because I mean, you're giving false hope for no reason, and you're just causing more problems than you're going to help. So keep that in mind on that end. Let's see here. Amniotic fluid embolus. Okay. I personally, thank God, never had one of these that I am aware of. I have heard of them, but I've never seen one. It's basically when amniotic fluid enters the pulmonary and circulatory system through the placenta. So it backflows into the mom. And basically what it does, her body sees it as an allergen. And so it goes into a response on that end. And it can include respiratory distress, hypotension, cyanosis, and even possible seizures. Keep in mind, whatever's happened to moms happened to that baby. And so this is something that when you see the signs and symptoms, you're just going to treat them. Okay. If mom's having shortness of breath, you're going to put her on oxygen. If she's hypotensive, you're going to treat that. So again, you may not know this is what's going on. She may not know what's going on, and the OB may not ever thought that this was a possibility. But you're still going to treat the mom every way that you need to. You're going to just support them. You're going to do a rapid transport with this patient. And it's going to be one of those things that, you may find out later that's what the reasoning was. And hopefully you were able to get them there quick enough and that you can treat and that they can be okay at that point. So hopefully so. Okay. Breech presentations. Okay. This is definitely something you don't want to have in the field. And unfortunately, there's a good possibility you may see it at some point, sometime. It's either going to be an incomplete or a complete, to where you've got an arm or a leg or something presenting itself. And normally the baby is the wrong direction. Okay. And instead of the baby being head down, they're head up. And you may have arms crossed, legs crossed. Keep in mind, it's trying to push this baby through the canal with appendages in the way, arms and legs and limbs instead of the head. So everything that can get caught is going to get caught at that time. Basically, position the woman. If the buttocks are presenting first, if you see the butt popping out there, you're going to present them at the edge of the bed or the stretcher with their legs flexed, in, and allow the newborn's buttocks and trunks to deliver spontaneously. So hopefully, kids are flexible. They're nothing but cartilage pretty much. Their bones are still soft and malleable. So if the butt's coming through and the legs are up and over, there's a good chance you will still get a good delivery at that point. And you may have to work around the arms and stuff like that. But once the legs are clear, then you need to support the body, okay? Because if not, everything will just be hanging there, okay? So you need to support it and lower the newborn slightly to see if you can start to get it out. You may even need to rotate just a little bit to help get the shoulders clear at that time. And that's if you've got a bottom, producing at that time at the breech birth. And again, once the hairline is spotted, basically once you've got the baby coming out through a breech, let's say that they were coming out buttocks first, the legs were coming out. Once you start seeing a hairline or where the hairline would bend, you've got about 3 minutes. Then that baby needs to come out or they're going to suffocate because they're going to start breathing. Their body's going to kick in and they don't have an oxygen rich environment where they're at that time. Do not forcibly try to pull them out. Okay. But what you can do is grasp their ankles, okay, and lift them upward. Basically, what you're doing is by lifting them upward, you're bringing that head down and will allow, hopefully, it to deliver a lot easier and a lot quicker at that point. But we need to try to do something and get things going within that 2 to 3 minute period so that baby does not suffocate at that time because they're going to, okay? Rare breech presentations, okay? A foot transverse presentation or an arm or things of that nature, you cannot deliver in the field like this, okay? If it's got 1 foot down and 1 foot only, it's not like you're going to be able to pull that baby all the way through, okay? This is a mass emergency. This is something you need to get to the most closest appropriate facility that can handle this in an ER to where they may need to go in and do a cesarean or whatever, or somebody that is definitely a lot more knowledgeable about manipulating that baby to get it out. So this is something that you've got to be very, very careful of. So if you've got a leg presenting and coming out by itself, then and only one of them, you definitely do not want to deliver that baby. You want to get them to the facility as quick as possible. if you've got a baby that's coming out that has got shoulder issues to where you cannot get them coming, where they are not coming through like they should, if they cannot clear the birth canal, at one point, the fetus is not going to be able to breathe at that time. Major concern for the newborn is a brachial nerve plexus damage, which is not good. However, on the same token, not breathing is too. So, I mean, we're going to need to get that baby where they need to go as super quick as possible. However, if you've got a shoulder presentation, what you can do is hyperflex the women's legs tightly to the abdomen. So you're going to get them as close and as tight as you can and apply pressure to the lower abdomen and gently pull the fetus's head out at that time. And that's if you got those shoulders stuck in there to where they cannot move at that time. So basically that's about the only good thing we've got position wise that we can do, is just to get those legs as tight to the abdomen as possible, to get them flexed up as much as possible, to give us the most amount and most room of that cervical canal that there is that we can utilize. So we're just trying to separate that symphysis pubis and that canal and make it as big as possible. And also by doing that, you're lowering that head a little bit to try to help get us a little bit more movement when we're trying to get that baby out. Again, we already talked about a nuchal cord, where the cord's wrapped around the baby. Most of the time, you can do this just by gently running the head with your finger, getting under that cord, and just flipping it back over the head. Don't yank on the cord, obviously. You may only have movement one side or the other. So if you start to move that cord, you may need to go to the left or the right, depending on if you just won't completely come over. And it will usually be pretty slimy. So it will usually be lubricated enough that you can get it around and off the neck of that patient. So, and again, if unsuccessful and you cannot, if the head's presented, delivered, and you got a nuchal cord and you cannot get it unwrapped from that baby, clip and cut. That's your last resort, is clip and cut that in order to get that baby out, because they're going to end up suffocating if you don't get it clear. So gently try and move it. If it does not move and you cannot get it out, clip it, cut it. So just get it where you need to at that point. Prolapsed umbilical cord. Luckily, I've not ever seen one of these. With that, what can happen is the baby's head can push down on that. It's going to decrease the blood flow, which decreases the oxygenation to the baby from the placenta, and it can lead to asphyxiation to that patient. What you're going to do on this is you're going to keep the woman supine, if at all possible, with the hips elevated, because what that's going to do is take the pressure off of that baby and that cord, and hopefully, make this to where they can start breathing again. We're going to give the mom 100% oxygen, non-rebreather. Have them pant with their contractions to help get more oxygenation in at that time. And we're going to gently push the presenting part back into the vagina until it no longer presses on the cord. So we're going to gently, whatever part, that is pushing against that, we're just going to take that part back up into the vagina until it no longer presses on the cord at that time. That's the only time we push back in, is when it's pushing on that cord. So we're going to try get her hips up and everything else. We're going to try to gently push in and push that cord out of the way, so that because what happens is that basically that cord is presenting itself as that head is coming down that birth canal, and that head is pushing, or shoulder or whatever, whatever is pushing against that cord, and it's pushing down on it and holding it to where it cannot get any blood flow. Well, no blood flow, no oxygenation. Now we're going to have asphyxiation. So we've got to do something. And again, best thing you can do, put mom on her back, elevate her hips up, push up or push slowly, push that presenting part back into the vagina just until it's no longer on that part, and see if you can kind of manipulate that cord around a little bit, to get it out of the way. If not, then you're going to hold her that way until you get to the hospital, so that they can, get in there and do what they need to do, because, that's beyond your purview out in the field. But this may be the only way that you end up saving mom and the baby at that time. So, okay. All right. see here. Go. Okay. Last but not least, I want to just real quickly touch on postpartum hemorrhaging. Okay. And basically, it can be either early or late hemorrhaging with your patient, and postpartum is one of those things that can happen way after delivery. So it's something that you got to consider even with a woman that's no longer pregnant. Early bleeding can be within 24 hours of delivery, and late bleeding can be 24 hours to 6 weeks after delivery. So knowing your history of your patient, again, is going to help you with this, knowing that they delivered a baby 3 or 4 weeks ago. So, and this can be very serious. That basically anything with blood loss that exceeds 500 ml during the first 24 hours after birth is definitely considered a postpartum hemorrhaging on this at this time. Basically, what we're going to do with this patient is we're going to treat it just like we would anybody that is going into hypovolemic shock. We're going to take care of that patient. And even to the point of doing uterine massages if need be. Okay, like we talked about, where you're massaging the fundus in that area and massaging the uterus area to try to get the body to stop bleeding, to help clot off that area and stuff. So that's about that. And treating for shock and doing what you can is the only thing that's going to help that patient at this time. Again, you're not going to pack the vagina in any way, shape, or form with any kind of trauma pads or anything like that. You're going to transport them immediately. You're going to get a large bore IV in, get some fluid started on that patient. But again, do not pack that area at that time. And again, if they were pregnant, or it's 24 hours before the labor, or they are, they've already delivered and it's been just 2 or 3 or 4 weeks, or even up to 6 weeks at that point, you need to keep in mind that that's a good possibility. But about, massaging the fundus into that area is about the only thing that you've got other than treating the shock on this patient at that time. So getting him to the hospital as quick as possible. Unfortunately, that could be a surgical intervention that they need to do pretty quickly to keep the patient from bleeding out at that time. Postpartum depression. This can happen and can appear up to 1 year after birth. And it is something that, unfortunately, due to hormonal or chemical imbalance or anything that's going on, that a mother can get. And it is, it shows all the similar signs to depression that you would deal with. Anger directed toward the infant at the time, little or no interest in the infant, thoughts of harming themselves or the infant. And keep in mind, this patient is not really in their right mind at that time. Doesn't mean that they're going to be a bad mother or anything. It just means that they need some help. And so this is something that you should take seriously at that time. And again, especially if she doesn't have any assistance or any help, she just got done, delivering this child, and now she's spending the next several months with no sleep, hardly gets to eat or anything else. It can make a person depressed, especially if they don't have somebody helping them. So keep in mind, don't necessarily start making accusations at the mother or anything of that nature. That's not our job. We're not there to judge. We're there to take care of the patient, both the infant and the mother. So treat them just like you would anybody, with respect, integrity, and everything that you can to help them out with that situation. Let them know you're there to help take care of both of them. Obviously, the hospital will get the police involved if they need to, but they'll know what to do from that point on. You just get them transported and do what you need to do to help them medically, or emotionally at that time if they need it. So, okay. All right. I know that there is a lot that goes on with OB patients, both with the baby and the mother. Those are just some of the high points that I thought were noteworthy, that really needed to be talked about. Again, I highly advise you to go through the entire chapter on both of these.